Hi, good evening, everyone. Thank you for attending today's FIP. We'll be talking about the Universal Health Coverage Competency Framework by the WHO. I'm Abigail and I'm from Singapore and a member of the FIP's Pharmacy Technicians Advisory Committee. I've been working as a pharmacy technician since 2013 in KK Women's and Children's Hospital, and I'm currently in charge of staff's training. I'm also an advocate for pharmacy technicians, and I'm part of several national initiatives and work groups. Intend to use this platform to better understand the needs of pharmacy technicians and with regard to progression and training of them. And I hope to use this to develop my leadership and mentoring skills. This webinar is being recorded and it's live streamed via YouTube. The recording would be available via the website at events.fip.org. You may ask questions using the Q&A text box. And you're welcome to provide any feedback to the website here at webinars@fip.org. To become a member of the FIP, you may choose to click on the registration link that's provided over here. Today's program will be doing an introduction on today's topic, the speakers, a Q&A, and conclusion. So today's learning objectives, we have an overview of the principles and objectives of the WHO Universal Health Coverage Framework. We want to use this to understand the competency-based education and its role in developing the global healthcare workforce for UHC. We want to use this to contextualize the UHC Competency Development Guide to fulfill training needs based on country of practice and to focus on pharmacy and pharmacy support workforce in UHC. Today, we have Sivan from Switzerland. She's a WHO technical officer. Sivan's a technical officer at the WHO in Geneva since joining the Health Workforce Development in 2018. She has led the development of Global Competency and Outcomes Framework for the UHC, which was published in April of 2022. The framework has been adopted by the WHO Academy to underpin the provision of its lifelong learning programs and provided the foundations for other competency-based education guidance published by WHO, including in sexual and reproductive health, eye care, refugee and migrant health. She coordinates the Global Health Workforce Network Education Hub and provides technical advice on strengthening health worker education across a number of areas, including human resources for health leadership and management. Sivan, please.
Wonderful. Thank you very much, Abigail, for that introduction. So it's a real pleasure and privilege to be with you to be able to share our work in competency-based education that WHO published earlier this year. So I'll start the presentation just to take a step back from competency frameworks and just really even talking about universal health coverage, which you will see in my first slide. So we published in 2016 the Global Strategy for Human Resources for Health, which really sets out the different approaches that WHO recommends for member states to strengthen their health workforce. So we think about education in the context of employment, so educating health workers that lead us to having a stronger health workforce. Abigail, if you could change slides, please. We also this year had a resolution adopted by member states, which set forward the action plan to strengthen the health workforce. And education is one of the fundamental pillars of this action plan. So education health workers is absolutely front and center to all of the work that WHO is doing to achieve universal health coverage. So in terms of the health workforce, when we talk about the UHC goal of all people having access to the health services they need where and when they need them, this requires a health workforce that is available, accessible, acceptable, and of sufficient quality. And this quality emphasis is really what we talk about or speak to in the competency framework. In my next slide, I refer to education in the context of the health labour market. So we know that any investment in strengthening education cannot be focused on education in isolation, but also looking at the transitions from education into employment, the entry points into education and the different policies to not only look at the content of what people learn, but also the influences of migration, of regulation. In my next slide, we look at the different key publications, I guess, in competency-based education. This is not a new phenomenon. From the first documents which were published in 1978 by the World Health Organization, which was really looking at the competency-based education for health workers. But of course, competency-based education has been around for decades before that in other sectors. There are many different interpretations and applications of competency-based education, and it is largely used to refer to outcomes-based education, which is really one of the fundamental points of the Lancet Commission report, which you can see on the screen, published in 2010. So where traditional models were focused on what health workers needed to know, this flips the emphasis from starting from health needs, health systems needs, to then what do they need to be able to do, and then what do they need to be able to know to do that. Next slide, please. So when WHO set about developing its global competency framework for universal health coverage, we really wanted to both identify what are the competencies, so what are those education outcomes, but also we wanted to be able to identify how different training institutions, different member states can use, can harness the potential of competency-based education to strengthen their health workforce. So the framework that we published is guidance that really focuses on what those outcomes should be. But also, I think one of the fundamental approaches that we took, rather than saying this is what a particular health worker group should focus on, or should be able to do, it's more, these are the activities of health practice, and what are the competencies to provide those practice activities? So it's very much focused on the functions of healthcare rather than the different occupational responsibilities. Next slide, please. So when we set about this work, it's quite a daunting brief. For universal health coverage, we focused very much on health practitioners, so clinical health workers with a sort of a mid-level training pathway, 12 to 48 months. There was a lot of already published information about longer training pathways for doctors, for example, but we really wanted to go into actually what are the competencies for health workers with shorter training pathways within that broader health team. So it's very much a consultative effort with the oversight of a working group for which Ian Bates, who will speak after me, was a very key integral member of that advisory and working group. So there was very much an iterative approach to what do we mean by competencies? What is it that we were trying to highlight and emphasize in the framework? And then going through the process of extensive consultation to ensure that this was relevant across jurisdictions, across occupational groups. Next slide, please. So here we were really thinking about that Lancet Commission approach. So starting with population health needs. So what do we mean by universal health coverage? So we looked at the different UHC indicators, the principles for the achievement of universal health coverage. So this goes beyond what somebody would do, but actually how are we trying to achieve that? So the emphasis on quality, the emphasis on people-centered care, social accountability of health worker training institutions, for example. When we talk about the determinants of health or digital skills, but what is it that an individual health worker needs to be able to do? So we mapped out an enormous amount of information from the existing strategies and documents and existing job descriptions, competency frameworks, to really try to navigate what were the commonalities, what was essential for universal health coverage, what was common between those different groups. So in my next slide, you will see the range of existing competency frameworks that we identified, more than 300, from a range of occupational groups, but there is a dominance, particularly from medicine, particularly from nursing. And I would also say from sort of North America, Australia, New Zealand, South Africa, many countries in Europe are widely published, but we actively looked to identify relevant documentation from all of the different regions. So this slide is really here to show what we found, but of course we wanted to then navigate through the content that we found rather than an emphasis on one particular group, because that was the volume of what we found, but to really then take a step back and find the commonalities between all of those different existing frameworks. Well, one of the things that we did find was the many different approaches to competency-based education. So in my next slide, you will see the model that we adopted. So competencies can be used interchangeably to describe all types of education outcomes, but we really wanted to clarify, in fact, we had to clarify the distinction between different types of outcomes, because when you then incorporate content from that framework, you use the different types of outcomes differently. So practice activities are what we refer to as the functional outcomes. So something you might see in someone's job description, what they are, so within their scope of practice, or something you might do or delegate to a colleague. That is what we call the practice activity. And it is only possible to perform that practice activity to the standard required for UHC if you have the competencies of the individual. And these are really the behaviors, things like effective communication or interpreting volumes of information and problem solving, decision-making under pressure. So competency-based education is oriented towards the practice activities, but the basis is developing the competencies of the individuals who will ultimately perform the practice activities. This is not to overlook the importance and the contribution of knowledge, skills, and attitudes. These are foundational. So when we're thinking about the competency framework, which really talks to those top two blocks, we also want to think about how it is relevant for education programs where you do need to think about the learner journey and the incremental acquisition of knowledge before you can get to the application of knowledge. Okay, that's the theoretical part over. I will now be able to show you the content of the competency framework. So this first slide talks to the competencies. We identified 24 competencies that are common across all occupational groups. So this is the first framework, we believe, that is relevant across these occupational groups. Like I said, focused on the 12 to 48 months, but actually through the process of validation, we identified these are also relevant to all health worker groups. So things like effective decision-making, people-centered care, placing people at the center of all practice. All health workers need to be able to convey information purposefully, to be able to apply the principles of evidence-informed practice. But when we think about what these competencies look like, we do need to think about what it is they do. So for example, when we're looking at communication, so adapting communication is an essential competency, but communication in the context of breaking bad news or writing a prescription form or managing a public health communications, that adaptation of communication looks very different. So these competencies and behaviors can only really make sense in the context of practice activities. But in turn, the practice activities can only be performed to the standard we need because people have these competencies. So in my next slide, within the framework, you can see that we have expanded each of those 24 competencies to what are the behaviors? How do we know if somebody has these competencies? What does this look like in practice? So in the framework, you will find each of the 24 competencies expanded. And I think important just to note, this is a very theoretical framework. In practice, you don't isolate a single behavior from another one, but in practice, somebody brings all of those together. So collaboration and communication and decision-making is absolutely integral and fundamental to practice. In my next slide, I can show you the overview of the practice activities. So this is thinking about the whole health team, not one or two individual groups, but collectively, what are the practice activities towards the achievement of UHC? So we focused not only on individual health, the patient pathway, taking a history, writing prescriptions, developing treatment plans, monitoring that treatment plan, performing procedures. So things that you will see on an individual level, but also what is the role of the health worker towards population health, and some of the management and organization responsibilities, documentation, for example, managing resources. So in this overview, actually, one of the things we wanted to highlight was some of the outcomes that we found that people do in practice, but are not necessarily common as education program outcomes. So we want this framework to also provide a reference for, are we training health workers to do everything that they will ultimately do? Because unless we're training them to do the full scope of their job, there is that risk that the quality would not be there. It wouldn't necessarily come through the clinical side, but actually in handover, in documenting, this is some of the common areas where practice can be strengthened. So again, in my next slide, I just show you briefly what this looks like in the framework. So we have illustrative profiles. We talk about the practice activities, but in a way, these are quite abstract unless you know what it is you're looking for. So we've illustrated what this might look like for a nurse, for a community health worker, for example. And there are knowledge guides, very broad level. So things like knowledge of the diagnostic procedures. But of course, you need to know what are the procedures, what are the presentation of symptoms. So this needs contextualization for this to be useful. But this is a collection of the references, the different sort of knowledge content, the different practice activities and tasks that you might have as your education program outcomes. Next slide. So just going back a little bit to the theory again. So why are we doing this? And ultimately, we want to have health workers who are competent to provide health services towards UHC. So we know that competence develops on a spectrum. So starting from you might know something, know how to do something. And then when you are able to do it safely on multiple occasions. So again, this is one of the principles of competency-based education is not just a single observation of has somebody done this, but can they do it in different contexts and different situations? And then in practice, proficiency will continue to grow. So we also within WHO, even going beyond this framework, we emphasize the importance of safe transitions, supportive supervision. My last couple of slides are really looking at, so we've got this big framework, how do we adapt it? So when we're thinking about the different aspects of the health workforce, next slide, please. So the framework is the sort of, here is the overarching reference point for all of the competencies, all of the practice activities towards universal health coverage. But we need to see this used. So we want to see this translated into education outcomes, into standards. So they set the outcomes, and that outcome needs to be common between education, employment, regulation. So it needs to be adapted. And then from those sets of outcomes, you can then develop whole curricular programs that embrace their competencies and situational learning, group learning, and so on, and learning in clinical settings. So last couple of slides, looking at how actually pharmacy and the pharmacy workforce informed the work and can be, and the framework can then be adapted out to the pharmacy workforce. So in my next slide, I show you actually where we started from when we were thinking about the health worker groups with a 12 to 48 month pre-service training pathway. So this is the ISCO reference. This is a document that the International Labour Organization publishes to define the different responsibilities of different occupational groups. So the blue bars are where we started from. These were the groups we wanted to highlight their contributions within the framework. And you can see, as you would expect, that all of the ISCO responsibilities are indeed reflected in the Global Competency Framework. But I think one of our more interesting findings was then when we went back to that initial list to validate that we had indeed captured the full scope of those practice activities, we found that the framework is indeed relevant to many other groups as well, including so I'm trying to read some of this. So general medical practitioners, because we have taken this quite a high level, performing procedures, that is relevant across multiple groups, but you then need to specify out what procedures, under what context, under what level of supervision. I will say that even though we have a 100% alignment going back, there are other sort of tasks within the ISCO groups that we chose not to include. And my next slide, I'll highlight just a few of these. So you might want to think about, in addition to the Global Competency Framework, actually some of these might be relevant when you're adapting the framework. So for pharmacy, for example, testing and analyzing drugs, or evaluating packaging, for example, of medicines. So we were very much thinking about the interactions with individual patients, but these are, of course, some of the broader roles that different occupational groups might have. So in my last slide, just thinking about, so how do we get from the global competency framework to reviewing existing education outcomes or creating new ones, new standards. So it's really thinking about gathering the information. So we have this comprehensive reference, but we also need to think about who is it for? So when you have the occupational group in mind, what are their responsibilities? What are the practice standards? What other sources of information are there? Not just about what somebody does, but what does that look like? So those competencies and behaviors that we highlight, but what does that look like in the context of the role responsibilities? And I think very clear that this is consultative and iterative, and there will be quite an extensive process just to validate this and ensure that this does meet the needs. So I will stop sharing the content there, but I will stay for Q&A, and I look forward to the discussion. Thank you.
Okay, and we have Professor Ian Bates next. Professor Bates is the director of the FIP Global Pharmaceutical Observatory. He is the chair of the pharmacy education at UCL School of Pharmacy as head of education development, as well as editor-in-chief of Pharmacy Education, an international research journal hosted by FIP, which has been published peer-reviewed educational research continuously since 2000. And a fellow of the FIP, Royal Pharmaceutical Society, Royal Statistical Society, and a trustee for the European Pharmaceutical Students Association. Professor Bates, please.
Thank you very much for that introduction, Abigail. And thank you to Siobhan for that tour de force of competency-based education and explaining so clearly the vision of WHO in terms of human resources for health and workforce development. I will pay tribute to you because it's a significant piece of work. And I know personally just how much effort and energy you put into authoring this document, which I do believe is a seminal document. And this is one of the reasons we're having this initial webinar today, to broadcast further the work of WHO and to start us thinking about another layer of integration that we will be putting into our own global policies for workforce development. So this is a starting point, I think, for further work and further dissemination of the WHO framework. And certainly we will be revisiting this in Seville in September as part of a major discussion and presentation and panel theme for our global conference in Seville. So thank you. It's a fantastic piece of work. So I enjoyed doing this first slide, and the enjoyment was trying to get as many three-letter acronyms into the title as I possibly could. I could have put more in, I think, but we will be talking about universal health coverage, primary healthcare, FIP, of course, because we're about to look at contextualization of Siobhan's work, and WHO. Our world seems to be dominated by three-letter acronyms. I'll see how many more I can put in as we go through. Abigail, next slide, please. I'm going to start with primary healthcare, and I'm going to start with the Astana Declaration. Here's the FIP delegation to Astana, which of course was a WHO conference, 2018. And I'm starting here because FIP made a significant commitment to the Astana Declaration about primary healthcare and the challenges of primary healthcare in the context of universal health coverage. We went on to sign a memorandum of agreement in a year later with Dr. Tedros and his team from WHO. And we are working our way through this MOU with WHO right now. And the knock-on effects, I don't know what to call it, the trickle-down effects, the influence that this has had on global development and national organizations, national professional leadership organizations has been quite immense, actually. It's maybe a piece of work I need to take up with Siobhan, just to show how much influence this has had on our own global policy development. Moving on to pick apart on the next slide, these primary healthcare commitments. We are in a process at the minute of translating a lot of the policy thoughts into mechanisms and programs of action. Our general label for this is Health for All, which is, I think, a broad enough title to encompass all that we are doing. And the next slide shows us how, sort of schematically, we're trying to bind all this together with our recently launched global development goals, of which more later, and the WHO framework for universal health coverage, which has been recently rejuvenated as well. I love this, the strapline, Health for All, Everyone, Everywhere. I think that really does encapsulate what our collective and shared global vision should be about primary healthcare, and the contribution of all the healthcare workforces in that for this particular challenge. The next slide gives us a bit of a timeline. On the right-hand side there, we have 2030, and one of the slides that Siobhan showed us previous to this was the WHO Human Resources for Health strategy, which actually has 2030 as a kind of deadline to get something done. It's also very much a warning milepost as well, because unless we shift our actions somewhat, we are going to be disastrously short of healthcare workers by 2030, including pharmacists, including nurses, including family doctors. We really do need to focus on healthcare workforce capacity, building that, and of course, building new scopes of practice to cope with the primary care challenges, which Siobhan has outlined in a very clear way in her presentation. You will see that we are currently in 2022, so we're looking now at actioning our commitments and getting programs up and running, which I'm delighted to report is actually happening. FIP has got an enormous amount of activity going on across all the regions and across all our sectors with this ambitious program. 2023, next year, which is rapidly approaching, is an important year, as it's going to be a health ministers summit hosted by FIP. And the intention here is to report on progress and to stimulate further action through the health ministers about pharmaceutical services provision, the community basis of primary healthcare, about how we manage medicines more effectively, new services that are needed for the primary healthcare challenges, etc., etc. And there's quite an enormous amount of effort going into that milestone as well, including a whole library, a collection of evidences pointing towards the 2023 goal, which is our sustainable agenda for pushing forward the profession worldwide. Next slide, please, Abigail. This just highlights just a few, literally a few, of many commitments we have made to actions on primary healthcare. Obviously, to support Astana with continued progress. More specifically, redeveloping sustainable models of care, particularly in community environments, access of our populations to medicines expertise and management of medicines. That's what we're meaning there with sustainable models of care. And of course, we need to develop capacity of the workforce. We can't have one without the other. And that will then mean that we need workable, pragmatic transformation policies to be made available across all of our workforce, from our pharmacy assistants in communities through to certified technicians, registered pharmacists, and credentialed experts. Okay, so we're sort of now looking at how we can apply or integrate the WHO framework across all of our strata, but maybe with a particular focus on pharmacy technicians worldwide to begin with. Next slide. These drivers are probably very familiar to all of you. The right-hand side, it tries to encapsulate in a couple of words Siobhan's mission, which is a flexible workforce and a competency-based approach to workforce planning. That obviously means both capacity and, critically, education, training, and further development of the workforce. Those drivers on the left-hand side are pretty familiar. Our changing demographics of increasing longevity. So we're all living longer, which is good news, but we're all living longer with more comorbidity, and we're all taking more medicines as we do grow older with increased comorbid pathologies. So governments, our knowledge and technology acquisition, our use of medicines and our technology with medicines, and our services all are driving this vision of a flexible workforce that is competency-based in its continued development. Thank you, Abigail. Here's a reason why. It's a very common reason why. A very typical patient in a hospital, which I randomly selected recently. I got one of my friends to just go and pick up a set of case notes for me. And this is very typical. She's elderly. She's got a lot of comorbidity. She's taking a shed full of medicines to deal with this comorbidity. She's in hospital only for one reason at this moment, and that's because she has a urinary tract infection, a UTI. That needs fixing in hospital. She needs rehydrating, and she needs to go back home to her domiciliary environment where she lives. She doesn't live in a hospital. She lives at home. And continuing the care and management of this complexity, that slide there, all of you will be aware that behind every word on that slide is a shed full of complexity that needs to be managed. That's the primary healthcare challenge. And she is a very, very typical patient. Long-term conditions, complex disease, complex medicines to go with it. This is why we've chosen with WHO to promote the competency-based education and training route. As the next slide, I hope, shows in as few words as possible why we are changing this focus to CBET, competency-based education and training. Because it's about outcomes, i.e. what we do, and performance, how we do it. That road from competence to competency to performance is what we are going to try and encourage and provide support for our professional leadership organizations and individuals to achieve that. Our role and the WHO role is to provide support in what we're calling an adopt and adapt approach to it, mentality to it. It's really getting a culture of workplace education and work-based learning, which is how this all works. And that's going to be, I think, a new way of viewing CPD for us. Next, please. This was historically one of the documents that really started us thinking very, very hard about the global workforce. It's a WHO document with an alliance of workforce experts, Global Health Workforce Alliance, which later transmuted into an active unit within WHO. And it tells it all, just the title of this document, No Health Without a Workforce. Well, you know, our version of that is no pharmaceutical services without a pharmaceutical workforce. And that's why the focus on workforce is so very critical indeed. What did we do after this? I think this was 2014, this document. The next slide shows a response from FIP, which was 2016, about mechanisms of transforming our global workforce. And we started to gather together a series of programs and mechanisms that would support transformation of the global pharmaceutical workforce. And the right-hand side of that shows some examples of where these mechanisms have been taken up by leadership organizations and members of FIP. That was back in 2016. This has accelerated and grown since then. And indeed, the next slide shows a couple of papers we produced very recently. I'm trying to think when. It might be 2021 or 2020, having a memory loss now, where we were able, because we had so much evidence going on, and in parallel with Siobhan's work about looking at what was going on throughout all the professions. This is our little pharmaceutical corner of the world, and looking at competency development frameworks, a systematic review and a meta-analysis. And Siobhan, although she didn't mention, there's a little chart that she showed on one of her slides earlier on, which had a kind of like an exponential, it looked like an exponential growth pattern in the use of competency frameworks. The pharmaceutical ones for our pharmaceutical workforce were very, very similar to that. It's a little bit more linear, but it was absolutely in that upward trend of the increasing use of competency-based frameworks to help push forward scope of practice, to help push forward the performance and the continued growth of our global workforce. Let's keep going, Abigail, and show, oh, sorry, yes, and here's the one we're talking about today, which we're now hoping to incorporate into our integrated global approach as an adopt and adapt mechanism. 2021 saw the launch of these global development goals, which again was a product of Astana. There are 21 of these launched in 2021, which I find particularly pleasing from my the statistical half of my brain. And they have proven to be remarkably, and I'm astonished about the rapid uptake of these globally by leadership organizations throughout the world. There's a long way to go with these. One of our big jobs recently, and the next two slides shows how we're doing this, is to start to take all the mechanisms behind these and to map them to the universal health coverage framework. So the operational framework, if you like, the primary healthcare framework, we've tried to map our own goals to those and to map the programs and activities associated with them. So you can see the basic three columns there. You can see the second row down, the primary healthcare workforce. A lot of our work is now oriented towards that. A lot of our development goal activities are oriented towards this primary healthcare theme, because that is where we shine. And if COVID has taught us anything in pharmacy, it's just how influential, life-saving community access to vaccines and medicines can be for our populations. Pharmacists have saved countless lives over COVID through providing medicines expertise and access. And that is a major example that we'll be using, certainly with the health ministers next year. Moving on, I think there's just a little bit more on this slide to show. There it is. More strategic levers here about how at a macro level we need to address this as well. Funding and resources, of course, is critical, but policy frameworks and commitment, and not least leadership. And this is a webinar today is part of the dissemination of leadership and awareness of what we're doing. I need to move on because I'm in danger of overrunning, and Marwan and Abigail will start to shout at me very soon. Siobhan has shown you this and explained it very clearly, so I don't need to, fortunately. But the point I would like to make from this is the adopt and adapt methodology, which WHO supports and we support. It's about providing structure for others to look at, to adopt and adapt, not having to reinvent wheels, not having to duplicate effort, where effort has already been successfully expended in developing things to begin with. The next slide similarly shows how the greater layer of detail is actually mappable. It's directly mappable to the work that we've been doing. And none of you will be surprised by that, because we've had an intense interest in competency development frameworks in FIP for quite a while now. And Siobhan and her team took notice of that. We have taken notice of what Siobhan and her team have done as well in a two-way way. And we continue, I think, to develop and interact in close alignment. These words that you see on there are not unfamiliar to us at FIP. We will jiggle around some of our frameworks and we will make them more clearly aligned with the WHO work. That will add to clarity. That will add to people being able to see the big picture and to show that we're not working in a pharmaceutical silo with this. We are working in an integrated way. Let me dive a little bit deeper and show you why. On the next slide, this is one of our original frameworks, the Global Competency Framework. We're on version 2 of this now. Some of the words in there you will have seen on the previous slides because, hey, that's what we were trying to do at the time. The next slide shows us how who this is intended for. This is really a framework for early career years of pharmacists and to support foundation training for pharmacists. We absolutely went along and adopt and adapt modality right now, and many leadership organizations across the world have done exactly that. They've adopted and adapted to suit their own cultural background, their own professional habits and traditions. But we are achieving unity and harmonization. One current project now is to take this framework and start to look at it from the pharmacy technician's perspective, which is why Abigail is here with us today and Marwan. And this is a significant project that we're working through right now. Next slide is another example of what goes on later on in careers, so the Advanced Development Framework. Again, if you look at the words on the left-hand slide there, these general clusters for this mid-career, mid to expert career stages of development, familiarity with it, because we took notice of evidence, we took notice of what was going on, and we developed an evidence-led approach to it. The next slide tries to show you how we did that. This is one example in Indonesia where we took a large sample, over 6,000 pharmacists, and we looked at mapping them across these frameworks, and that sort of, it's a bit of fancy statistics we did here, but you can clearly see the clusters that were going on there. And what this slide is really showing is that these stages of development of careers are valid and they're credible, and we can have frameworks which reflect those stages of career development. And this is now being implemented in Indonesia with their global leadership body and their Ministry of Health. In actual fact, it's been a very successful case study of transformation, transforming the workforce to be better suited for primary healthcare. And we're still gaining many results from this particular experiment. Moving on. An earlier piece of work, because we were keen to prove the notion of transferability, generalizability, or maybe better described as transnational applicability. And this is sort of the adopt and adapt methodology. We did a crossover study with some of these competency frameworks. Admittedly, these were English-speaking countries, but we showed proof of principle. And in fact, the Indonesia example we just had there, we had that as Bahasa in actual fact. So it was all translated, and we did test out this adopt and adapt across language barriers as well as across national barriers. So they do work, and they are transferable, and they are useful. So let's not worry about that anymore. Let's just get on and do it, because the evidence and the proof is now there. Abigail, let's move on. You'll all be super happy to know that I'm coming to the end. A couple of more examples. This is very recent. We are all aware of humanitarian disasters in the world. Go back to Indonesia again, some very terrible earthquakes and floods that they've been having, through to conflict zones. We have Ukraine going on at the moment, and FIP working very hard with Ukraine to get medicines and pharmaceutical workforce upskill to help with it, as well as other natural disasters, so on and so forth. And our military and emergency response section at FIP has developed a humanitarian framework based on work we've done. So this is not entirely new. And again, you will see the words and the cluster frames there familiar, because of course it was based on our previous work with the GBCF. And moving on, Abigail, the other current work underway, which is most important, and this is something we're really trying to speed up, is looking at our technicians, certified technicians, ensuring that there is similar global support there. We are looking at educators. We are looking at handbooks for all of this. We're looking at a wider range of specialist frameworks as well, to be used in primary healthcare setting. So, but perhaps sort of disease-led or long-term disease-led development frameworks to have an additional layer of performance education layered on top. Thank you, Abigail. I believe this is the last slide from me. So what's our direction of travel? Competency-based education and training as a workable solution to better workforce development. WFT, there's another three-letter acronym for you. Mapping and alignment to be absolutely crystal clear about integration with the WHO HRH policy development. Another three-letter acronym for you, Human Resources for Health. We are greatly influenced by the work that WHO does because it's so good and relevant, and we want to make sure we are aligning ourselves with that. An integrated global approach that meets the current needs and challenges. Siobhan started off by saying that we do need to tackle the health issues in the world, and an outcomes-based approach to developing the workforce is the only way, the only sensible way really that we can do it. And to continue to develop our library, if you like, we can call it a library of evidence-led frameworks for the pharmaceutical workforce that covers the entire pharmaceutical workforce. So it's work for the next 5 years at least, I think, right now. And one of my big messages today for you is, let's not reinvent the wheel. Let's not replicate work that's already been done. Adopt things and adapt things, and short circuit the time it takes to transform workforces. We haven't got time to waste. 2030 is going to be here any minute. We need to move on, and we need to move on rapidly. That is for sure. Thank you all very much for listening to my waffle this morning. You'll be pleased to hear that I'm done.
Thank you, Professor Bates. We'll move on to the Q&A session. Can I invite both of you to turn on your videos and microphones? We have some questions here. We'll start with Savon. What is next, and how are you disseminating and working with health education institutions or universities to implement this framework?
Super, thank you. So absolutely, we want to see the framework being used. So WHO actually works across 3 levels of the organization. There are regional offices, and then there are also country offices. So in any country where you are seeking support, the best approach to do that is to direct the request for technical support through the country office. And we can certainly respond to requests that get elevated up to us. But the intent is very much we want to see it be used. One of the chapters in the competency framework is actually high-level guidance on how to adapt it. How do you then go about developing or strengthening curricula? So there is already a solid reference, but then we do want to see that get used. And I know there are a number of countries, particularly in the Sierra region, who have expressed interest in doing so. Within the organization, we are also adapting and adopting the competency framework. So many of you will have heard about the WHO Academy, which is our provision of lifelong learning. So the Academy has adopted the competency model, so the focus on outcomes as practice activities, but also the UHC competencies. And there are a number of other products that have been adapted already. So there are migrant and refugee health competency standards, and the recently published iCare competency framework as well. So very much using the same approach, but really tailoring that to whether a specific set of services or a specific learning course. Over.
Thank you. The next question's for Professor Bates. We know that there's a migration of healthcare workers from country to another. For example, in disaster areas, pharmacists and support workforce are also migrating. How would this affect the UHC? What are the pros and cons for the UHC?
Thank you very much. That's a good question, and it's something which is surprisingly hard to measure as well. We know quite a lot about how nurses migrate, and we know quite a lot about how doctors and physicians migrate. We know less about why and how pharmacists migrate. We do know it happens. We do know there are some unique areas in the world. So the European Union, for example, have a free movement agreement, so pharmacists can move from country to country without having to be re-regulated, if you like. So there's harmonization of the professional regulations. We also know that pharmacists do migrate for different reasons, and that we have some ongoing work with that right now. The transnational applicability of global competency frameworks, in theory, makes it easier. And we are beginning to see the emergence of ways in which countries and regulatory authorities can start to use this as a harmonization mechanism for it. We have a long way to go. I'm sure any colleagues on the call who may be associated with regulatory authorities know that they are very big ships. When they start to move, it takes a long time for a regulatory authority to move, change direction. It does happen. I, as a Canadian organization, was in touch with me this week about some of these work-based assessment tools, for example, linked with competencies. So I do know it's of interest to them. It's going to be a long game, that one. Definitely a long game, and we do need to know more about migratory patterns and drivers for pharmacists, but work is underway, and we'd be delighted to hear from anybody who wants to help us with that. My friend Dr. Marwan, who is on the call, is leading up a couple of migratory projects right now. We'd be delighted to hear more, but harmonization through the use of WHO frameworks, through the use of FIP frameworks, is clearly one way forward for doing that.
Thank you, Ian. Got more questions for the both of you. How do we standardize the education so that we can make sure that we're having the minimum requirements that would help in the UHC?
That's a really tough question. I'm going to get Siobhan to answer that one first, and I might follow up after.
Okay, so I would actually interpret that question as we're talking about standardizing the education outcomes, not about standardizing the education approach. So actually how the curricula is delivered and how different people learn. But it is important for us to be able to standardize education outcomes, particularly where it is linked to regulation. So that might be within a country, a specific scope of practice. But this is very much then the authority or the responsibility of the regulatory body to be able to set what those regulated activities are. And I guess there are different models to do that within each country. So this is also an area of work that WHO does have some forthcoming guidance that we are going to be publishing, I think, towards the end of this year, which is actually around how do we ensure that the regulatory system is stronger and works to its potential as well. Over.
I was correct. Siobhan was the perfect person to answer that difficult question. I'll add in that FIP has a regulators forum. So we do have a global collection of regulators who meet hosted by FIP to discuss these issues. And we are part of a global consortium of regulators as well, who meet on globally on a regular basis to discuss these matters. I think the key words that Siobhan said were really about harmonization of the outcomes. We can't interfere with national authorities, national competent authorities, and we have no wish to. But harmonization of the common purpose, I think, is probably the way, I think, that the FIP Regulators Forum is discussing right now. So please, again, there are more more FIP units that you can join in with if you have an interest in regulatory matters, for sure.
Okay, we've got another question for the both of you. The importance of CPD for UHC.
I've got a short answer.
You go first and I'll add.
Oh, okay, here is my answer. Yes, is the answer.
Super. So very similar. It's essential. I think we recognize how much practice evolves. So even when you are graduating from the pre-service education, absolutely competent and ready for practice, we know that practice needs updating, that individuals where your practice experience might be in one area and then your job changes and you need to have a bit more experience in another. So CPD, lifelong learning, is absolutely essential to ensure continued competence, to ensure that the workforce continues to be upskilled and maintains existing skills. So very much we want to ensure a culture of lifelong learning across all of the occupational groups. We know that CPD is particularly strong in some occupations and less strong in others. And this is something which we do want to encourage. Over.
Mm. We're mapping CPD criteria across 150 countries right now. So we've got a pretty good idea of how it's shaping up. Remember what we've been talking about today, what Siobhan has developed at WHO and us as well, are mechanisms. They're supporting structures for CPD. And we're doing it in a way that actively contributes to your daily work. So it's not something that's removed from CPD, it's a support structure for CPD and pushing people's careers forward and pushing service development forward. So they're not separate things, it's a mechanism for doing CPD.
Okay, let's do two more questions. This one's for Ian. The adopt and adapt model seems to be the way to go. My question is how this model of CBE intend to work in developing countries like Kenya, where I come from.
Great. So talk to us is the answer, and we'll help. So the Indonesian example I showed you was where their professional leadership body, the IAI, in conjunction with their Ministry of Health, said, this looks like a good idea. Can you sort of show us how it might work? So we talked with them. Then they said, can you show us how you might be able to help us? So we talked with them. And then all of a sudden, we have a national program of transformation up and running. And it cost, let me just think about how much it cost IAI to do that. Quick think, it cost them almost no money whatsoever, because we had the tools, we had the experts to talk with, we had the teams willing to put it in, and it was done for virtually no cost. Honestly, that's the point. FIP has got a huge interest in low and middle income countries and a huge interest in equity, equalizing, getting that equity agenda for everybody, for all countries, for all citizens on the table. So talk to us, talk to Dr. Marwan here, and if you want to do a major transformational project, we are all ears on that.
I think this answers one of the questions on how this can help low-income countries like Nigeria. Last question is, pharmacy study stuffs that doesn't include more pharmacy public health related sections. I think it's in the chat. You guys have any take on this?
I think we've had a really good generalized set of questions, Abigail, going through. I can't see anything specific that we can help on. Siobhan's done a great job in explaining the big pictures and how it all fits together. I hope I've done something about FIP.
Actually, I can see there is one question in the Q&A, the third question that's been asked. So in terms of what role for individuals?
What role can one play as a pharmacist in developing countries to drive UHC using global competency framework, and where does one start?
Oh yeah, I can see that.
Well, yeah.
FIP works through the national leadership bodies as well as individuals. So the first step would be your professional leadership organization, and finding out where they are in this whole development matrix, and then coming to talk with us afterwards. But it will have to involve this is national stuff we're talking about, filtering down to individuals. So that would be the starting point, I think. It's kind of like how WHO works, isn't it, Siobhan? You work through your member organizations as well, but
absolutely. I interpreted this question as actually, how do you, it's your advocacy strategy. How do you get influence? So if you're trying to influence the regulatory body as an individual, I feel so far removed from that. But I guess but who can influence that? So is it about sort of disseminating the work and building capacity sort of within institutions or across institutions? So I think it's really also about identifying who has the power to make changes, to implement, to adopt, and then working backwards. So how are we going to get there? So it can feel quite daunting as an individual, but it's about building that network and building the evidence base and the arguments for change as well. Over.
Okay, thank you, speakers, and thank you, participants, for joining us this evening or afternoon. I'd like to share about the 80th FIP World Congress that's happening in September this year. We're very excited to invite you to the 80th FIP World Congress of Pharmacy and Pharmaceutical Sciences in Seville, Spain. The Congress will take place from the 18th to the 22nd of September in 2022 under the theme Pharmacy United in the Recovering of Healthcare. Registration and abstract submissions are already open. For more information, please visit their website, and you may choose to register before the early bird deadline on the 15th of July. Thank you very much. And good evening, everyone.
Great. Thank you.